afternoon and good evening to our distinguished speakers, chairs, and audiences of the ACNS webinar. This is the 7th session of our anniversary edition of webinars, and we have two great speakers who are going to enlighten us with their very insightful lectures. The first speaker for today is no stranger to us, and he's a very popular neurosurgeon. And it is my great honor to introduce you to Professor Andrew Kai. Professor Kai is the director in the Department of Neurosurgery at the Hadassah Medical University, Jerusalem, Israel. He was the previous director of neurosurgery at Royal Melbourne Hospital. He was appointed professor of neurosurgery at the University of Melbourne, the first of its kind in Australia in 1997. He was appointed the James Stewart Professor of Surgery and the chairman of Department of Surgery. He was the past president of the Asia-Australasia Society of Neurological Sciences and also the vice president of the WFNS. He is the founding editor-in-chief of the Journal of Clinical Neurosciences. He has received several awards and honors for his outstanding contribution towards neurosurgery and neurosurgical education. He was the recipient of the Bittner Award in 2003 from the American Association of Neurological Sciences and the Busey Award in 2006. He was awarded the Commonwealth of Australia Centenary Medal in 2003 and the Order of Australia in 2004. In 2010, he was awarded the Medal of Honor from the WFNS for his outstanding contribution to neurosurgery. He has authored and co-authored more than 200 journal articles and book chapters, as well as 5 books, including being the co-author with Dr. Edward Laws of Brain Tumor, a text recognized as being the definitive work on the subject. We are extremely honored to have him today as a speaker at our webinars, and he'll be talking about management of recurrent craniopharyngiomas. The speaker for the second session of today's webinar is Professor Llewellyn Padiachi from Pretoria, South Africa. Professor Padiachi is the professor of neurosurgery at the University of Pretoria and also the chief specialist pediatric neurosurgeon at the Steve Biko Academic Hospital, South Africa. Professor Padiachi's interest in ultrasound led to an outstanding doctoral study of the use of transorbital ultrasound in evaluating intracranial pressure in collaboration with the engineers in Trondheim, Norway, and an ensuing patent is being taken to market by Nisonic, a great example of neurosurgical innovation through interdisciplinary collaboration. He is an invited faculty to various workshops organized across the world, and he's also a noted author who has presented several articles in various leading journals. We are extremely honored to have Professor Padiachi to be a speaker at our webinars. Today he's going to talk about intraoperative ultrasound in neurosurgery. The chair for the first session of today's webinar is our honored guest and very senior faculty from India, Professor Chandrasekhar Deopujari. Professor Deopujari is the professor and head of the Department of Neurosurgery, Bombay Hospitals, Mumbai, India. Professor Deopujari is the chairman of the WFNS Neuroendoscopic and Neuroendocrine Committee. He was the past president of the International Society of the Pediatric Neurosurgery, and he has a vast experience in dealing with children with brain tumors and various other pathologies. He is a noted author with several publications in various internationally acclaimed journals. We are extremely thankful to him for accepting our invitation to chair today's webinar. The chair for the second session of today is Professor Francesco Prada from Italy. Professor Prada has been a neurosurgeon at the Department of Neurosurgery at the IRCCS Foundation Neurological Institute, Carlo Besta, Milan, Italy, where he shares his interest between clinical practice, focusing mainly on oncological surgery, skull-base, pituitary surgeries, and spinal surgery and research, studying the application of ultrasound for the guidance and treat neurosurgical pathologies. Dr. Prada has published more than 90 articles in various peer-reviewed journals and was the editor of a book on the intraoperative use of ultrasound in neurosurgery. He is also editor and reviewer of numerous scientific publications. He has given presentations and conferences at national and international meetings. We are extremely honored to have him as a chair for the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I'd like to welcome both the speakers and chairs and audiences to this online platform to the ACNS webinar. A very warm welcome to all the distinguished faculties, Professor Atul Goel, Professor Ibrahim Sibe, and all others who have joined in from different parts of the world. Special welcome to Dr. Binoti Damodar, who is the assistant professor in neurosurgery at the Government Medical College, Calicut, who is the special co-host for today. Dr. Liu Singh from Malaysia is my regular co-host. Welcome, Liu. May I invite Professor Andrew Kai. You may start your lecture, Professor.
Thank you very much for asking me to talk at this webinar. I'm very grateful to be speaking in the company of such eminent neurosurgeons and colleagues, many of whom I've known for many years. And I'm going to talk on craniopharyngioma and the changing paradigm in the treatment of this really very, very difficult disease. And I'm going to give you some concepts of what I've been thinking about over many years of trying to treat this very difficult tumor. But first of all, I really want to acknowledge the Asian Congress of Neurosurgery and their webinar series, and particularly Professor Yoko Kato, who has really been a pioneer in so much of Asian neurosurgery. The craniopharyngioma was first described by Yakov Erdheim in 1904 in Vienna. And it was recognized by Harvey Cushing as being the most formidable of intracranial tumors. It accounts for about 3% of intracranial tumors totally, 10% of pediatric intracranial tumors, but I would note that this is, whilst it accounts for 10% of pediatric tumors, 60% of these tumors occur in adults. Most people think of it as just purely a pediatric disease, which is not correct. And the problem with this tumor relates to what is a considerable excess mortality and morbidity for what is biologically a benign tumor, but results, as this study shows, in considerable excess mortality, particularly in the childhood onset tumors, and considerable morbidity. There are four main patterns of growth of these tumors, either intracellular, those that grow in the supracellular region, the third ventricle, those on the dumbbell sort. Most of them are the supracellular form. Of these tumors, 50% are cystic, 15% are solid, and the two main histological varieties are the adamantomomatous group, which are particularly the pediatric tumors, and the papillary, or the adult group, which tend to be solid. And it's particularly interesting that these two groups are now being underpinned by various molecular oncogenesis of the tumors, and this is particularly an important point in terms of future treatment of the tumors. The tumors present particularly in either visual failure, hormone disturbance, raised intracranial pressure, and epilepsy. The problem with these tumors are that they especially involve the hypothalamus and the optic pathways. And it's this involvement of the hypothalamus and the optic pathways that lead to the morbidity of the tumor, but especially not just on a presentation, but also on treatment. And it's this intricate involvement of the hypothalamus that has resulted in a problem that's associated especially with the attempted total removal of these tumors in childhood, in that the children will live, but often in with very significant morbidity associated with hypothalamic damage. And it's that has led a number of studies, particularly European studies, to reassess the treatment of these tumors. And this particular study from Neuro-Oncology in 2015 came to the conclusion that gross total resection of these tumors involving the hypothalamus, particularly in children, should be avoided because of the amount of damage that is caused. Now, the neurosurgeons have often been criticised because we have no clear protocols regarding treatment of craniopharyngiomas. But I think this is unfair because these tumours present in so many different shapes and sizes, and the tumour treatment really needs to be tailored to the particular patient. And of the treatments that we have at the present time, they can involve surgery, which of course is the mainstay of treatment, and the question is then regarding the extent of resection of the tumour, or whether or not you just drain the cyst. The radiation therapies and which particular form of radiation should be used. Chemical therapies, particularly since the concept of various particular molecular genetic changes within the tumours, which may be susceptible to targeting by chemotherapy agents, and in some cases just observation. Now, it's well been known that even radically resected tumours have a significant rate of recurrence. And in this series with Dave Lunsford in 1999, 25% of radically resected tumours were noted to recur, and the adamantomomatous group, or the pediatric group, are known to be more likely to recur. We look at the various studies looking at recurrence, there's a considerable difference in the percent of mortality, the percent of total removal of these tumours, and in the recurrence. But what is important to understand is what percent of the series were paediatric groups or what percent were adult groups. This is a very important study by the late Andrew Passer from UCSF, which showed in a systematic review of surgery and radiation therapy, there was no significant difference in terms of the control of these tumours, whether or not the tumour was completely resected or there was partial resection with radiation therapy. And in this study from UCSF, there was an argument that the aggressive resection led to increased postoperative neurological and endocrine deficits. This led the European group to recommend a shift towards much less radical treatment and hypothalamic sparing treatments, particularly in childhood craniopharyngioma. And this, of course, was a dramatic change to what we saw, say, from a decade or 2 decades earlier, where it was the whole point of the treatment was total resection of the tumour. But radiation therapy itself is not without complication. And this was a very important study from the MD Anderson, probably one of the best groups in terms of giving radiation treatment, in which they looked at long-term disease control and toxicity associated with IMRT. And their conclusion was that despite the use of IMRT, the majority of craniopharyngioma patients experienced long-term toxicity from the treatment. So here we have a problem of damage-related, morbidity-related resection, morbidity related to radiation therapy. So when we tried to look at our series of what the complications were, we tried to look at them very carefully in a longitudinal study. The main ones we saw, of course, relate to neuroendocrine and diabetes insipidus, cognitive problems, visual changes, and what was been reported in the past is a mortality in these groups between 0.5 and 5%. So I divided my series both from when I was in Melbourne and since I've been in Israel, in Jerusalem, between 1985 and 2020, 165 patients into. These were primarily treated patients, and that group, second group, which were treated as recurrent tumours. And in the primarily treated patients, 165 of them, most of the patients presented with visual failure. At the time, some of them had hydrocephalus. At the time of presentation, the majority had hormonal disturbance. And this was primarily an adult group of treated patients. And of those who present with visual failure, I'd remind the residents who are watching this webinar that the classic optic pathway compression of producing a bitemporal hemianopia often as the back of the chiasm results in what's called the bow tie atrophy appearance, as shown here on the fundus. And in this series, was able to obtain a total resection as assessed by MRI in 102 patients. But despite that, there were 6 recurrences extending from 3 to 8 years, of which 2 have been symptomatic. The other 2 were not the others were not symptomatic. Of those patients that had a partial resection, as assessed by postoperative MRI, and that's why the series is from 1985, where we could assess this on postoperative MRI, there were 9 recurrences, of which 3 were symptomatic, and of these, 54 had radiation therapy. And 2 patients, there were just cyst drainage. Now, in the group of 84 patients who had recurrent craniopharyngioma, and the vast majority of these were young adults who had been treated as children and who had then been passed over to adult neurosurgery, although some of them were paediatric patients that I've been treating here in Jerusalem. 84 patients. they presented with imaging changes only on 16, visual failure in 67 of them, so the vast majority of them, and virtually all of them had major hormonal disturbance at the time of presentation with a recurrent tumour. Now, many of these, as all experienced neurosurgeons know, can have, with recurrent craniopharyngioma, who've been waiting a long time, very complex situations with often multiple shunts inserted, and who have quite considerable morbidity at the time of their recurrence with hormonal changes, cognitive changes, and visual failure. And of these patients who had recurrent craniopharyngioma, the 84, I was able to obtain a complete resection in the 47, but still had three of them had recurrences up to 1 at 8 years. Now, those who had a partial resection, which was dictated by the tumour characteristics, then there were 4 further recurrences, one of them being at 7 years. But only one of these so far has been symptomatic. And these are recurrences on MRI. When I looked at the surgical approaches that I've used, many different forms of craniotomy have been removed. I've used over the years, experimenting with different approaches to the tumour. In the majority of the cases with primarily treated craniopharyngioma, I've used a pterional approach, or if the tumour extends up to cause hydrocephalus, a transcallosal approach. But more and more over the last 8 years, using an endoscopic transnasal approach in these tumours, basically dictated by the position of the tumour. And in those patients with recurrent craniopharyngioma, the majority, again, I've used a pterional approach, although I'm aware that many others use many different forms of approaches, and increasingly the extent going to use an endoscopic transnasal approach for the treatment of these tumours. Now, I know that many people don't use a pterional approach. Many prefer some form of subfrontal approach, but I've used this because I think that it has given me better access through the various channels of access to the tumour, either in front of the chiasm, behind the chiasm, or to the side of the optic nerve chiasm and optic tract between the carotid artery, or alternatively sometimes laterally to the carotid artery. So this is a classic form of craniopharyngioma, in which case I've been able to approach the tumour between the optic nerve and chiasm and the carotid artery. This patient had previously had a resection, and the patient had diabetes insipidus, so I divided it in this patient the stalk. As you can see there, using a endoscope, I was able to see, even though I thought I had a complete resection there were still some little fragments using the endoscope after the tumour resection. On this patient, you can see another typical classically looking craniopharyngioma extending in the suprasellar region, and for various reasons decided to use a pterional approach. But on looking at the gap between the carotid and the optic nerve, although we were able to get into the tumour and identify the stalk, wasn't really able to get much tumour out from this position. The tumour seemed to be very stuck, so I went through the lamina terminalis, and it seemed that the tumour was really quite stuck onto the hypothalamus in this region. And we looked at the endoscope afterward, but I just make the point that in this particular tumour, in fact, it wasn't a craniopharyngioma, but rather a choroid glioma of the hypothalamus, which is a very unusual sort of tumour which mimics macroscopically a craniopharyngioma. But it does demonstrate the position of going through the lamina terminalis. For those tumours extending up into the lateral ventricle, through the third ventricle up to cause hydrocephalus, I found the transcallosal approach really very helpful. We're involving being very careful of the anterior cerebral artery, going through the corpus callosum, identifying the tumour in the foramen there, going into both sides to identify the tumour to give good access, removing the tumour through the foramen of Monroe, typical looking craniopharyngioma, then being very, very gently peeling. In this case, it came off the hypothalamus really in the walls of the third ventricle really very easily. You can see here down here the suprasellar membranes coming into view just here, and going on to the other side, doing the same thing and being able to remove it fairly easily from the suprasellar area. On the other hand, if you look at this sort of large tumour and the angle of approach, you'd say these tumours actually, particularly the larger tumours, and especially if they extend down into the pituitary fossa, really lend themselves ideally to a transnasal transphenoidal approach, because you're directly in the line of the tumour, and because of the axis of the tumour, makes them fairly straightforward to remove, now using particularly endoscopic techniques. And here we're taking the last fragments of bone off the carotid. See the pituitary gland has been exposed, dividing the dura down here so we can mobilise the pituitary gland down, the extending between the pituitary gland, between the pituitary gland and the optic chiasm, seeing the base of the tumour in this particular region here, diatherming it, the base of it, using the CUSA to remove it. It's quite solid, this one. And you can see it's in the lines in the direction of the tumour. The tumour lies in the direction of the approach. And then using the endoscope to look in at the end of the procedure. And you can see in this particular case, we've left a little bit of tumour here. And so very easy to see with the endoscope, and then able to remove this bit of tumour with the CUSA again. And at the end, looking in, so it looks quite clean, and the top of the basilar artery being just in this position. You can see the basilar artery pulsating. Now, the results of these patients, which have been prospectively collected over these years, of the 165 patients who have presented, who had primarily had surgery, 124 of them and 148 had improved vision. So some of them had normal vision to start off with. So 148 had impaired vision, 124 had improved vision, but 6 of this series had deterioration of vision. And in all of these patients, these were patients who had been operated on via a craniotomy. None of the patients who were operated on via a transsphenoidal approach had any deterioration of vision. We had only one patient with a CSF leak, and I can talk about the way we stopped the CSF. I've learned from others about how to, particularly to prevent CSF leak in transsphenoidal approaches. No mortality. When we looked at the neuroendocrine outcome, of the patients who had total excision, 75 of them had new diabetes insipidus. The partial excision, 23 of them had new diabetes insipidus. And we looked at other hypopituitarism in these patients. 25 of the total excision had ended up with hypopituitarism, and 10 of those with partial excision ended up with new hypopituitarism. So 35 of the 60 had new hypopituitarism features. Of those patients with recurrent craniopharyngioma, the 84 patients, 47 had a total excision. The vision was improved in 29, but worse in 3. The partial excision improved in 16 and worse in 3. So only about 50% of these patients were we able to improve their vision following surgery. The same in about 40%, but significantly worse in 7% of patients who had recurrent craniopharyngioma. And in trying to identify the features of those where visual outcome was impaired, those patients with optic atrophy, they had a much worse outcome. The size and the extent of the tumour played an important role. The length of symptoms, the preoperative deficit, and the adequacy of surgery, I think, probably is a major cause. But prediction, as always, can be difficult. The OCT, though, has been very helpful in determining the patterns of recovery following, particularly in pituitary surgery, less so, but it is still important in patients with craniopharyngioma. Now, in terms of other possible treatments for patients with craniopharyngioma, of course, radiation therapy has been the mainstay over many years, and there's been this big argument between radiation treatment and surgery. With the onset of highly focused radiation therapy, particularly with a gamma knife or with other forms of highly focused conformal beams, either with proton beams or photon beams for treatment, this was thought to be possible to revolutionize the treatment of craniopharyngioma. But you'll be aware of this paper by Michael Brada, who is really one of the doyens of radiation therapy, and particularly in his warning words for treatment of craniopharyngioma, that whilst there has been a considerable temptation to use radiosurgical tools such as a gamma knife or the cyber knife and using hypofractionated regimens, the results of the radiosurgery have been generally disappointing, with worse tumour control and without lower toxicity. And the use of hypofractionation has not been based on long-term results. Intracystic therapies, particularly for childhood treatment, for childhood tumours, has also been used. I haven't had a big experience in this, with just, as you can see there, a few cases, but the use of radioisotopes, bleomycin or interferon alpha, has been widely advocated for the control of, especially in terms of trying to preserve hypothalamic function for as long as possible in children. And that has proven to be quite successful, particularly in the very young children, and what has been known now as the critical importance of preserving hypothalamic function to prevent the problems of especially morbid obesity and cognitive damage associated with hypothalamic injury in these children. I think, though, that what has been especially interesting and what could be the future for the treatment of craniopharyngioma is the results that we've seen with papillary craniopharyngioma to targeted therapy, particularly the identification of the BRAF mutant in these, and the use especially of dabrafenib in the treatment, quite dramatic results in some of the reported cases in the papillary craniopharyngioma. Now, whilst this has been the case in papillary craniopharyngioma, the use for the other signalling pathways have been aberrations, and other signalling pathways have been identified, particularly in the Wnt signalling cascade. And these might be other possible targets in the future for what is really a formidable tumour for surgeons in trying to not just perform a radical resection, but trying to reduce what can be the long-term, very serious morbidity, especially in children, adolescents, and young adults associated with hypothalamic damage. The difficulty has been in these that we can, whilst we've been aiming in many cases to do radical resections and get complete removal of these tumours, and we can show beautiful MRIs post-operatively. The problem is in seeing the child or young adult growing in from adolescence into adulthood 10, 15 years later when they end up with very major morbidity. So I think that there really has been very much a change in the paradigm in our concept of treating these tumours, where possible to absolutely to tailor the treatment to the patient, considering the age of the patient, the position of the tumour, the consistency of the tumour, but especially what the neurological injuries are, neurological damages at the beginning by the tumour. And then considering the options in terms of extent of resection and very much trying to preserve, particularly in the younger patients, further hypothalamic injury, and balancing the radicality of surgery with what we know can be in the long term producing morbid changes of those affecting the hypothalamus, and understanding that whilst radiation therapy may be effective, that it also has its drawbacks, and it's a matter of very careful balancing between these two treatments, and perhaps the future lies in biological therapies. But certainly, whatever we do, we need to be collaborating very closely together in neurosurgery with neuroophthalmology, endocrinology, and the radiation therapy, and tailoring the management plan to the patient. I'd like just to finish off by letting everyone know about the Asian Australasian Congress of Neurosurgery, which the Asian Congress of Neurosurgery will also be joining. It will be held in Jerusalem, Israel in September next year. It will also be joined by the European Association and the AANS. This will be a wonderful opportunity for neurosurgeons across Asia, the Australasia region, to meet up, hopefully after Corona, and have a face-to-face meeting. So all surgeons are very, very welcome, and please put it in your diary. And thank you very much for your attention, and I look forward to any questions. Thank you.
Thank you very much. Professor Pujari has joined us.
I'm terribly sorry, Raja. I got a little delayed in the OR and could join after a few minutes. Thank you, Professor Kai, for a wonderful and a very elaborate lecture. I would talk mainly about the recurrent, and you have a big cohort of almost 84 patients of recurrent craniopharyngiomas, which you talked about. One statistics or flavor we could not get from you is what was the percentage of children in that 84 patients?
So virtually all of them were patients who'd been treated as children and who were recurrences. Right. So what had happened was they may have been, now some of them were, a few of them were my own that I treated as children, but the vast majority had been treated at another hospital as children, and then had recurrences, and then had come on, and so they were treated then as adolescents or 16-year-olds or over. But the vast majority of them had started off as children, probably about 90% of them.
So basically, I think in the age group which we are treating, and you have shown that you have been able to get a fairly radical excision in these patients, in over 50% of these patients with good results, which is something which is becoming more and more being questioned, as you have yourself talked about later. Do you think the approach should be different for an adult and a childhood craniopharyngioma?
Yes, well, thank you for saying they were good results. I don't think my results in these, I hope I didn't give the impression that these were particularly good results at all in recurrence. I think what I was trying to show in recurrent craniopharyngioma, the large percentage of them, 90% of them had significant hormonal problems. Some pre-surgery, but virtually all of them after surgery. And only in less than 50%, about 50%, did the vision improve, and in 7% the vision was very much worse.
Right.
So I thank you for thinking they're good results. I find these results actually very sobering, and particularly
Good in the
related.
sense of you got much better sort of extent of resection than what I thought what is possible in recurrent tumors.
I think that my attitude for these has been very much influenced. I mean, we're all children of our evolution of our environment. And I grew up in the days of Fred Epstein, saying you need to remove it all and you do everything possible to remove it all. But then when I noted that the visual outcomes weren't that great, less than 50% in the recurrent tumors were to improve, a lot of them ended up with severe endocrine disturbance. And looking at what the results from the European studies came out, very much I felt that perhaps I was being too aggressive on these. And I've become much less aggressive on the recurrent ones. I mean, the worst thing is to give these children, these young adults, a bad visual outcome. They're already impaired. Many of them are very, very much impaired by their hormonal problems, and then to damage them further is not doing them any good at all. In terms of is there a difference? I think there is a very significant difference between the pediatric group, pediatric and young adolescent group, and the adult group. So those patients who presenting over the age of, say, 30, 35, 40, I think you can afford to be generally much more radical in terms of resecting, because the hypothalamic injury generally doesn't seem to be that serious. Also, I think that these tumors are much less likely to recur. The adenantiomatous group, the pediatric group, are much more likely to recur than the adult group.
Thanks for that explanation. And I think the attitude with recurrent tumors is a little different than the primary tumors, as you just showed us. Another question another point which you have made is very, very significant, is that the SRS, though it is very widely practiced in Europe, does not seem to be a sort of correct or the perfect treatment for these tumors, because of the visual outcome as well as the hormonal outcome. But more importantly, it is difficulty in defining the target, because many a times a flimsy cyst wall which has been left behind may not be seen properly, and target may not be as precise as this, and therefore probably a fractionated treatment is better. I think that point was quite well as you brought out with Prada's paper.
Yes, I think that's very true. And I mean, for instance, when I use the endoscope to look now where I think I've removed it, I think I've got a good removal. Now using the endoscope, we do find some more fragments there, and these fragments are often scattered. And where it is often stuck underneath the chiasm in a position that I'm very wary about removing it because of vascular injury to the chiasm, especially in recurrent tumors. And I think the more focused, it's the paradox, the more focused the treatment with radiation, the more likely it is you're going to get a recurrence, because you're going to get it from an area that has not been treated. And particularly if you're giving the treatment around the chiasm, then I think you need to be extremely careful in terms of what is a chiasm, an optic chiasm has already been damaged by the tumor. Have to be very, very careful in terms of having radiation toxicity in that region. And I remember a patient of mine about 3 years ago who I thought had a good result following surgery. She had a visual field defect, which had been present preoperatively, and it was no worse. Following radiation, though, she developed a full-blown hemianopia, which you could see the radiation damage within the chiasm and the optic tract. So I think that these visual pathways are much more susceptible to radiation injury than ones which are normal visual pathways, and that needs to be recognized and given in the dosage.
Just one more query before we have some senior people in the audience. Professor Goel is here, Ibrahim is here, and several other friends are here. But my last question is, if there's a purely cystic recurrence, which is more common in children and the adamantinomatous variety, do you adopt any kind of more conservative approaches?
I think very much so. I think now with the recurrences, particularly in children, do everything possible to avoid damaging the hypothalamus. So maybe just cyst drainage. Personally, I don't see that many of them. I've been involved in a few of them. And I've seen a few of them done here where I actually haven't personally been involved. Cyst drainage, bleomycin, interferon alpha, to wait as long as possible for the child to mature, and to give as much time as possible to not injure the hypothalamus.
So I think many things we agree on, but I'm sure there will be some other opinions. So Dr. Raja, if we have time, maybe Ibrahim wants to speak, and I'm sure Dr. Goel is looking forward to saying something.
From 40 years of speaking on panels with Dr. Goel, I am certain he will take issue with what I've said, and I look forward to hearing what he has to say.
No, Andrew, you talked on a subject which is absolutely, I consider craniopharyngiomas as a unfinished chapter in neurosurgery. You see, whether it is a benign tumor or whether it is not a benign tumor, it is like chordoma. You see, histologically benign, but behaviorally, nobody knows what will happen. Nobody knows exactly how much should be removed. You said that radical resection is good, and you also said that partial resection is not that bad with recurrences. You also said that whether radiation is good or not so good, whether any other kind of treatment is good or not so good. So there are enigmas, there are problems all over the place, whether you should do just a partial resection and do radiation, whether you should attempt radical resection. And I must say, over the years, I have now, from small resection to large resection to radical resection. Now today, I will say, in my opinion, radical resection is a good form of treatment. I'm not saying controversies apart, but my feeling is that radical resection may just be the best form of treatment. Other treatments, whether small resection, but even as you mentioned, that radical resection, you do a radical resection, you do a total resection, despite the post-operative issues. Radical resection is not without post-operative issues. In the post-operative period, there can be hormonal disturbance, electrolyte disturbance, chemical disturbance, convulsions, and so on and so forth. So radical resection is good, but radical resection is not easy. That is one. It is not easy to perform. As you showed some beautiful cases, it is not easy. It is difficult, and even with the best of hands, it is wrought with various possible complications and even hypothalamic disturbances and even death. So whether it is the best form, whether you should do, whether you should not do, what about recurrences? You talked about recurrences, how to treat recurrences. And if a recurrence has happened, we are actually dealing with a bad form of craniopharyngiomas. Some craniopharyngiomas are good types of craniopharyngiomas. I agree with you, Andrew, that recurrent craniopharyngiomas in general are most enigmatous of neurosurgical issues. And I hope you agree with the statement I make that the best form of treatment has not yet been clarified by you or by the literature. What do you have to say on this?
I would agree with most of that, Atul. I'd always like to disagree with something you say, but I would agree. I think that my feeling is that I have become much more conservative in my resection in children, adolescents, and young adults because of the damage that can result in hypothalamic injury. In adults over the age of 30, 35, then much more, then I agree with you entirely to try and do a radical resection. But I'm much more conservative in the adolescents, particularly and I see a lot of the patients in adolescents with this disease. And I absolutely agree. The best form of treatment is yet to come, and I'm hopeful, as I said at the end, hopefully it will be relate to the molecular genetics, finding targets for the molecular genetics of the tumor.
Another smallish point, Andrew. You talked about as Dr. Devpujari also talked about craniopharyngiomas in children and craniopharyngiomas is in older adults or younger adults. Do you think the benignness, apart from adamantinomatous pattern and pathological issues, you think the age itself suggests that the older the patient, more benign the progression of the tumor? Is that correct or is that not correct?
Probably, but I certainly think the damage caused by the in children and young and adolescents is far more profound than in somebody say over the age of 40. You know, they're quite, and the molecular genetic studies have been very interesting, seeing that there is a variety of these tumors. It's like glioblastoma, it's not one tumor. The molecular genetics has defined so many different forms of, like pituitary tumors, which has been totally revitalized, totally rewritten, the book on pathology, by looking at transcription factors. You know, and now finding that there's not just a patient with a growth hormone secreting tumor, they have a long list of different transcription factors, which then decide what the aggressiveness of the tumor is going to be. I think Ibrahim had a question. Ibrahim?
Yeah, thank you. Thank you, Andrew, for this brilliant presentation. It's, as I said, how nice to see you again. It's been some time since we met. I'd like to state my position regarding craniopharyngioma excision. I am with the radical excision rather than partial excision. As you all said, that the final chapter in the treatment of craniopharyngioma has not been written yet, so the debate will continue for several years. I'm just stating my personal stand on this. I believe I have to say this. There are certain points in teaching generations of neurosurgeons, and I call them bad teaching phrases and sentences. Some of them like, no plane of cleavage with the craniopharyngioma. This is nonsense. We all operate and we can find a plane of cleavage. Sometimes you can't, but sometimes you can. And in the majority of cases, you can. So the notion that there is no plane of cleavage for craniopharyngioma is wrong. Second thing, that surgery, radical excision, causes neurological deficits, causes endocrinological deficits, this, that, and the other, while partial resection and radiotherapy does not. If you leave a tumor, it will grow, and the tumor will destroy the nervous system and the endocrinological system. The use of shunts for craniopharyngiomas causing hydrocephalus, this is very bad. Now, I'm talking from the point of view that I'm living in Jordan, I'm living in the Middle East. Middle East, as in general, and Asia, most of the countries are developing countries. And the notion that we teach our residents that it is enough to take a biopsy or puncture assist and then send the patient for radiotherapy with a shunt is not good. These people would learn that this is the right thing to do simply because they cannot do the major surgery. So please think in two spheres of good craniopharyngioma surgeons and neurosurgeons in the developing countries. You have to speak different language for each group. To me, the practice nowadays in the Middle East, in the developing countries, is catastrophic. Most of the cases I see, puncture of the cyst, Ommaya reservoir, bilateral shunt with Y connection, as if it is a major discovery. I believe in this, that it is the mental state of the surgeon who goes into the surgery. First of all, you cannot decide from the images that you can or you cannot do radical excision. Radical excision or partial excision is decided intra-operatively. And if you find a plane of cleavage, you continue. If you don't find a plane of cleavage, you stop. Plane of cleavage, I mean with the hypothalamus. And we all know with the recent and so many papers written that the mammillary bodies and the floor of the hypothalamus just go on the sides. So on the MRI, you will not see floor of the third ventricle. The hypothalamic structures have been pushed to the side, so you can find the plane of cleavage. But to decide pre-operative that you just cannot do complete excision and then go with the state of mind that I'm going to do partial excision, this is sending the bad or wrong message to the young neurosurgeons, especially in the developing countries. I believe that surgery comes first. I believe radical excision comes first, and I believe radiation as an upfront treatment does not have a place. The last thing I want to talk about my observations on my cases. I have more than 120 craniopharyngiomas, and my observation is this, and this is for Atul, who mentioned that the difference between young people and adults. Atul, recently, in reviewing my cases, I found that adamantinoma numbers in adults are increasing in a very big way. So the idea that adamantinoma belongs to the young pediatric group and the papillary is for the adult, is to me is wrong, because I have seen lots and lots of adamantinoma in adults. The use of optic OCT, as you mentioned, Andrew, is very useful, preoperative and postoperative, for assessment of the neurological function. And the last point is about the obesity. We have two types: obesity that is existing beforehand, before you operate. This is due to the disease and you will not change it, or the obesity that happens after the surgery. And my observation in my patients, that you see, if you do radical excision, it is said that it will cause obesity. It's true, but the people don't mention that this obesity, especially in my cases, they disappear within 2 years' time. I can show you pictures and pictures of people getting obese after surgery. In 2-3 years' time, it disappears. So obesity should not be taken against radical excision. And my observation is that obesity is seen in young children. I have never seen obesity postoperative in adults. Thank you all.
I would just make one comment.
Thank you very
Ibrahim.
much. I think
Just one comment, Raja. I think if you sit with skull-based surgeons and discuss with them, craniopharyngioma is a different disease. And if you sit with pediatric neurosurgeons and if you have endocrinologists amongst them, it's a different disease. So I think you have to really see where and what patient you are treating. There is only one question which has remained unanswered from the box. Is the visual deterioration much less with the transnasal approach? Dr. Kai, Professor Kai, you could answer that before I hand it over to Raja.
And certainly that was in my, I don't know whether or not I just got better with years, but the visual deterioration, and it wasn't, we weren't matching patient with patient, so it's a bit hard to tell, but my feeling was that the visual outcomes were very much better with the transphenoidal endoscopic approach.
Over to you, Dr. Raja.
Hi, thank you so much. That was a very interesting discussion, and I'd like to thank everybody for giving their very valuable insights. We can now proceed to our second lecture, for which I would like to invite Professor Francisco Prada to say a short introduction.
Thank you, Raja, and thank you for asking me to chair this session. So Professor Prada is going to talk about ultrasound as a tool that can help us during our clinical practice, both in an intraoperative setting for surgical guidance, but also to monitor patients following patients after surgery and monitoring their status. And he will also provide an overview of how ultrasound can be used as a therapeutic tool. So now I'll leave the floor to my colleague and friend, Llewellyn. The floor is yours.
Thanks very much, Francesco. So you can see my screen, Roger?
Yep.
Let me see, I probably need to just enlarge that. There we go. Okay, good. So thank you very much, Francesco, for the kind introduction, and thanks to Dr. Raja for the invitation to talk at this prestigious webinar. Always been a fan of the ACNS educational activities under the oversight of Professor Cato, and I also want to acknowledge our senior neurosurgeons who were in attendance, Professor Kay, the speaker, Professor Gould, Professor Chandrasekhar. So it's a huge honor, like I said, to talk about something that I'm particularly passionate about. And like I said earlier, it's a thrill to have Professor Prada oversee this or chair it, because a lot of the work or some of the things I'll show at the end, he's been part of. All right, so ultrasound, the background really, ultrasound as a basic overview applies to all sound waves with a frequency above the audible human range. So that's about 20 kilohertz. There are two really broad categories of the use of ultrasound in neurosurgery. The first is diagnostic, and the range, the frequency ranges from 2 to 18 megahertz, really depending on what the applications are. And I'll touch on some of these and really the organ that one wants to image. So whether it's the orbit or the optic nerve or the brain itself. And then therapeutic ultrasound, which is something that's gaining quite a bit of momentum in recent years, particularly the use of high intensity focused ultrasound. And there the range really is from about 260 kilohertz to about 690 kilohertz, so quite a low frequency. And the principle really is that these reflected waves are detected by the scanner as an image as they sort of bounce back towards the probe. So it's interesting, and I like putting up the slide because I think not many people are aware that the early medical applications of ultrasound, so all the way back in 1942, Carl Dussek was the first physician to describe the use of ultrasound in medicine. And he used it to describe what he thought, and we'll see on the image in his publication, was what he thought was the ventricle. So from a sagittal view of the brain, he thought he was imaging a brain tumor within the ventricles. Subsequent analysis of this proved that it was a lot of artifact, but he's still credited with the first description of the use of ultrasound as a diagnostic imaging tool in medicine. And this developed in many years to follow. So Ian Donald pioneered the use of ultrasound in obstetrics, which later evolved in cardiology and anesthetics. And these are really the specialities that use ultrasound routinely in a daily sort of capacity. Neurosurgery has lagged a little bit, and that's really because we're quite pedantic about our image quality. And recently, this is really coming to its own. So the use of ultrasound in neurosurgery, I would argue, probably supersedes any other diagnostic or imaging modality. So there's a diagnostic capacity. We can use it at the bedside for hydrocephalus, tumors, craniosynostosis. We can use it to diagnose raised intracranial pressure. Intraoperatively, the uses that have been described are in hydrocephalus for guidance of ventricular peritoneal shunt placements, fenestration in multiloculated hydrocephalus and other endoscopic guided fenestrations, to guide and tailor the bony decompression in Chiari-1 malformation surgery, to guide and tailor tumor resections, to assist in vascular surgery, vascular neurosurgery, as well as peripheral nerve surgery. Surgical tools, so the CUSA or piezo surgery, a lot of you would use that. I think you're familiar with the fact that ultrasound forms a fundamental component of those tools. And then I'll touch towards the end on the advances in ultrasound, things like 3D ultrasound, contrast enhanced, strain and elastography, and the therapeutic modalities if we get some time, things like high intensity focused ultrasound, and then the research capacity, things like neuromodulation or synergenetics. So as a bedside diagnostic tool, I've just added these for completeness sake, really. The main capacity is to decrease the amount of CT scans, particularly in kids. So I'm mostly now, not exclusively, but primarily a pediatric neurosurgeon. So a lot of the early experience I had using ultrasound was in children. So what we aim to do was decrease the amount of unnecessary radiation exposure in CT scans to improve early diagnosis as a follow-up assessment tool for ventricular size, especially in children who had a ventricular peritoneal shunt. And then also at the bedside was as a tool to diagnose raised ICP. We did some work in the optic nerve sheath diameter measurement. The other field is, or the other spectrum of this is transcranial Doppler measurement. So the principle of optic nerve sheath measurement using the ultrasound is to place the probe over the globe of the eye, and in an effort to image the optic nerve, This is then measured in a very specific way. And there's lots of work now describing the relationship between the optic nerve sheath diameter and raised ICP. And this is some of the work we did in kids, defining those cutoff values and thresholds. The difficulty, though, is the diagnostic accuracy. It appears to be quite sensitive, but not that specific. So there still needs to be some work done to refine the accuracy in that field. Transcranial Doppler, some of you would be familiar, also ultrasound-based. A lot more complex, requires a lot more in the way of investment of time and energy, but there are several studies showing a good relationship with ICP, others particularly in children showing that it's more useful in differentiating low, normal, or high ICP, but less useful as a quantitative estimate. So really more as a qualitative estimate of ICP. So this is a picture like using, so in any children's hospital, this is a common occurrence where kids, in this case, a 6-month-old child, had almost 15 CT scans in the period of 5 months. And oftentimes we just don't know whether these shunts are working or whether our endoscopic fenestration has been functional or not. And these kids are then subjected to lots of repeat CT scans. The difficulty, though, is the amount of radiation we expose these kids to. So just as a recap, a chest X-ray exposes you to about 1 day's equivalent background of radiation, a skull X-ray 5, a CT scan, the equivalent of 8 months worth of background radiation. So one CT scan about the same radiation content as about 100 chest X-rays, and at least a third of these kids will have 3 scans. And like we've seen, some of them very young can have, up to 15 scans. And the risk, the compound risk of brain cancer, the risk of leukemia is significant. So in a child under the age of 15 who's had 2 to 3 scans, the risk of brain cancer, the lifetime risk, trebles. So it's important in this context to remember that ultrasound is an optic nerve sheath diameter measuring technique, or transcranial Doppler is quite a useful alternative. All right, then coming back really to the bulk of the content is intraoperative use of ultrasound. So the modern neurosurgical theater is quite an evolving and often intimidating place if it's not a place that you spend a lot of time in. So when we have visiting students come in, it's often quite difficult for them to orientate themselves. We have neuronavigation systems, minimally invasive techniques, the microscope, the endoscope, endovascular ablation techniques, intraoperative image guidance, of which ultrasound is one, but there are also intraoperative MRI scans, CT scans, and fluorescence guidance techniques, as well as the sort of intraoperative monitoring techniques. So the ideal navigation technique, and I think ultrasound falls into this category, should be accurate. It should be reproducible. There should ideally be a dynamic or real-time feedback. It should, most of all, I found, be easy to use and learn how to use. It should be portable and cost-effective. And in kids, especially, the fact that it limits radiation exposure to the developing brain is incredibly attractive. So in my practice, the more I've used ultrasound, the more I found indications to use it. So in little kids with an open fontanelle, we use it routinely to guide ventricular catheter placement. It's become almost an indispensable tool now for me in brain tumor resection, both in children and in adults. And I'll show some images of those. To guide endoscopic fenestration in complex hydrocephalus, so multiloculated hydrocephalus, cystic intraventricular cysts, to guide sort of vascular lesion resection, AVMs, the vein of Galen, like I've shown as well, just to identify more diagnostically. For Chiari-1 malformations, I think there's a very special place for ultrasound. I'll show some of that now, and we can perhaps discuss more about that afterwards. And then depending on the type of probe you have, to guide intramedullary spinal cord tumor resections. So the necessities are quite important, and I will go through these fairly briefly, but one needs a dual window. So in a kid with an open fontanelle, you can image through the fontanelle, but generally the surgical craniotomy needs to be adequate to allow the probe. And most modern day probes don't really require you to extend the size of your craniotomy more than you normally would. You need to have a sterility protocol in place, so how you use it. Interpretation of image quality is incredibly important. So the spatial resolution depends on your probe frequency and size. Acoustic coupling as well will be something that's quite promising, and I'll show some images to explain that in more detail. Then the type of probe and user experience, perhaps the most important thing, one needs to make the effort to learn to use it correctly. And once you've done that, I think the indications just unravel. So I'm going to start off with the sort of indications in hydrocephalus. And this is a child, you can see quite small ventricles. We use the ultrasound through the fontanelle to guide the catheter placement. You can see the entry of the catheter occipitally into the ventricle, all real time. We could reposition the catheter quite close to choroid plexus there. And as I thought I positioned it quite correctly, we changed the orientation of the probe. And you can see in a coronal plane, I was a bit more lateral than I actually anticipated. So it allows you to correct that. And this real-time feedback, I think, is invaluable in these cases. There are two types of probes, really. The burr hole probe, which a lot of people use. I don't personally use that because I do a lot of the ultrasound work in children. Or you could use a high frequency phased array probe via the fontanelle, giving you the kind of image I showed previously. And this is sort of the transfontanelle approach with an 8 megahertz probe. So assessing accuracy in this case, so we did a study, and there are several other studies as well, showing that whether you assess this objectively, so using the Euclidean distance, or subjectively by this sort of grading system described by Hayhurst, the overall the conclusion by this work published by Martin Schumann suggested that ultrasound-guided ventricular catheter placement should become the standard of care in VP shunt surgery. And if you look at the data he presented and some of our own, in children especially, I think that's quite a sensible approach. So neuroendoscopy, like I said, the indications for ultrasound guidance is really the complex hydrocephalus. So there have been several studies published on electromagnetic neuronavigation. I think that's a fundamental tool. All studies using this underscore the fact that image guidance in neuroendoscopy is incredibly important. The difficulty, though, is as much as one plans the surgery preoperatively, as soon as you've fenestrated a cyst, or as soon as you get into a ventricular cavity, the CSF shift and brain shift makes all your preoperative planning quite redundant. So in that vein, the group from Israel published a small study, but they use intraoperative MRI scan in an effort to augment or at least control for this brain and CSF shift. And they found it helpful in redefining targets and found that combining these two modalities was pretty useful. Intraoperative MRI, however, is quite an esoteric tool. It's really still limited to kind of research context, and it's incredibly expensive and requires lots of support and infrastructure. MR ventriculography as well is a tool that was described to better delineate intraoperative fenestration of multiloculated hydrocephalus. The difficulty here was that the ventriculography could only be done preoperatively and then postoperatively. So if you hadn't actually fenestrated a locule correctly, you'd only know that after the procedure was done, and the child or the adult would have to be taken back to theater. As I'll show in a bit, our ultrasound ventriculography technique allows us to visualize this in real time during the procedure, so we could then fenestrate cysts that we hadn't fenestrated initially. The work by Martin Stravitsky still underscores the value of ultrasound as a guiding tool for neuroendoscopy, and he described the saline flush technique to basically show this microbubble that is injected, not in the classic sense of a microbubble, but intraventricular ventriculography. And I'll show that in a second. So this is the kind of images one could get with an ultrasound. You can see the sagittal view, beautiful delineation of the sulci gyri, the ventricle, showing the septation there with the catheter placed, or at least the endoscope fenestrating through that cyst. This is a coronal view, again, showing the tip of the endoscope. You can see the cyst here within the ventricle. Again, two pictures showing multiple loculations within the ventricle. So this is the typical setup that we use. Ergonomically, the ultrasound is placed just anterior to the endoscopy equipment, which allows us best line of sight. This is a typical case of endoscopic fenestration. You can see the different density here. This was a case where we aspirated, really. You can see we aspirated quite a bit of pus initially from that and allowed that to clear, and then went in again afterwards to fenestrate. So typically the sort of almost six-handed technique, if you like. So I have two assistants, one to maneuver the ultrasound probe. I perform the endoscopy, and there's a registrar who helps with the fenestration. So this is a typical example of what the ultrasound ventriculography looks like. We inject the saline flush, and you can see we want to know whether these two compartments communicate or not. And that's quite eloquently described here. You can see the air bubbles remain sort of contained in that space and don't communicate with the large cyst. So we know that that locule needs to be fenestrated. This is what the little microbubbles look like under the endoscope. They all sort of flush and then are removed during the procedure, so nothing remains afterwards. So this is the case showing an isolated ventricle. You can see as we inject the saline flush, again, it's retained within that cyst, so we know we haven't communicated adequately. This is the case in the sagittal view. Again, you can see the tip of the endoscope here. Just want to close that. Tip of the endoscope. And as we inject the flush, you can see the microbubbles sort of settle along the outside of the cyst there, which confirms the fact that we need to fenestrate this because there's no communication between those two compartments. So this is a case where we thought we'd fenestrated adequately. Turns out we hadn't. You can see none of the microbubbles actually get into that compartment on the other side. We then put the scope back in, open wider, and you can see now it gets all the way across there, which confirms a good fenestration. This is a case as well where we had to do a foraminoplasty, so we wanted to communicate the lateral and third ventricle. So what we're looking for here under the ultrasound is the flush getting all the way into the third ventricle and over to the other side. And you can see as we flush there, the microbubbles, if you like, all the way here, down there, onto the other side. So we're quite happy that we've done a good job. And this is incredibly useful intraoperatively because it gives you the added confidence to know that you've either done an adequate fenestration, or if you haven't, you can then go back during the same procedure and open that locule up. Okay, then in Chiari 1 deformity or malformation, the definition we know varies a bit, but effectively it's herniation of the cerebellar tonsil below below the level of the foramen magnum. So routinely what we do is get a cine MRI and demonstrate whether there's flow across the craniovertebral junction, and where there's absence of flow, it helps with interpreting the ultrasound images intraoperatively. So we do a bony decompression, and this is an image. It's a sagittal image, so that's the tonsil. The ultrasound probe is placed on top here, and you can see there's good pulsation of the tonsil, but it's quite difficult to interpret that alone. So we use the power Doppler function to see if there's any flow of CSF across that decompression. And on the bottom here, you can see there's movement of CSF across that decompression. So this is a case where we would then not go on to open the dura, because interpreting these images suggests that we have restored some sort of CSF flow across that junction. This is the case again with the patient lying prone. That's the tonsils. This is a case where we opened the dura and we had to shrink the tonsils. What we're looking for here is good pulsation. You can see there's a syrinx as well, and I'll show you how useful it is for the ultrasound to show that we've decompressed that syrinx. So intraoperatively, you can see good CSF pulsation. You can see there's still a bit of tension in that cyst, but good CSF movement. Once we've decompressed the syrinx, you can see the amount of movement here is a lot more. So the pulsatility across the decompression suggests that we've created more space. And then before we close up, do one more, and you can see that syrinx has collapsed now completely on this scan here. So this is quite useful intraoperatively to confirm whether one's done, the decompression that we wanted to, as opposed to with or without a syrinx. All right, then the bulk of our intraoperative use of ultrasound is tumor work. And this is a case that I did fairly early on before we actually got our ultrasound machine, a kid with what turned out to be an anaplastic astrocytoma. So did what I thought was a pretty good resection. A follow-up CT scan, showed that there may be some residual here, which I couldn't see under the microscope. So resected what I could see microscopically. But the follow-up MRI scan done 3 months later showed quite a recurrence in that area. So the argument here being, if I had an intraoperative ultrasound, I would have potentially picked up this residual and could possibly have resected that and had some sort of impact on at least the size of the recurrence. So the imaging of ultrasound intraoperatively, like I said earlier, has improved dramatically. So this is a coronal MRI scan. You can see the tumor in the posterior fossa. This is what the imaging looks like on the ultrasound. So really good quality images. This is an intraventricular tumor. That's the coronal MRI scan. And you can see the ultrasound here allows you to measure the size of the tumor, allows you to measure the size of the ventricle as well as the depth. And in addition to that is the ability to describe and define the vascularity. And I'll show that perhaps best here. This is a posterior fossa tumor as well. That's the pica vessels. That's the tumor itself. And these are vessels. These are actual tumor vessels, and these are the adjacent vessels. So it's pretty useful, both intraoperatively. It helps at least guide you in terms of which vessels you can sacrifice, which we should preserve, and then post-operatively, specifically in posterior fossa tumor, as you want to sort of confirm that the picas are both healthy and intact, which one can do with the ultrasound. The Doppler function as well is incredibly useful in picking up these vessels I showed, not just in tumors, but also in exclusively vascular lesions. Okay, this is a choroid plexus tumor. You can see involving the lateral ventricle and the third ventricle. You can see the vessel on the MRI scan, the coronal here. This is what the sort of standard ultrasound image looks like. Third ventricle tumor, lateral ventricle. So you can see the image quality is quite comparable. But the real value I started to find is determining the vascular, or at least locating and identifying the vessels. So you can see how much clearer that vessel looks on the ultrasound here with the Doppler function compared to what it looks like on the MRI scan. Again, just another scan demonstrating the quality of imaging. You can see the tumor delineation here. If you compare to the MRI scan, quite comparable. And then intraoperatively, that's what the tumor looked like on MRI scan. You can see it well delineated here on ultrasound. During the resection, thought I'd remove most of it, wasn't sure about the margins. You can see the ultrasound suggested there's a little bit of tumor residual there, which we went and resected. Looks like a nice clean margin here, and that's what the sort of floor of the fourth ventricle and aqueduct looks like pre-closure. So again, before one closes, it's quite nice to get this confirmation with intraoperative imaging. This is another one showing the case earlier with resection. It can be a little difficult to interpret these ultrasound images. So yeah, once the cavities collapse, there is this artifact, and that can be quite difficult. It is a described limitation of intraoperative ultrasound imaging. But again, I'm just showing a case of complete resection. That's what the ultrasound image looked like. And we laid some Surgicel along the cavity, confirmed by post-op scan. Determining, or at least confirming, residual tumors. So this was a kid we did with intraoperative monitoring and mapping. The kid became hemodynamically unstable. The decision was to leave this tumor against the brainstem. So we knew it was there. We confirmed that residual on the ultrasound. So when we did the follow-up MRI scan, it wasn't a surprise. We knew exactly how much we left behind. This is a spinal cord tumor. This is what the preoperative imaging looks like. You can see it on the ultrasound. And then post-resection, you can see this is just collapse of the cord. That's what the resection cavity looks like afterwards. Again, quite useful. It's a different probe that we use, but the imaging quality is really just as good. To come back to that point about the artifacts, a normal saline often gives you this artifact at the bottom of your tumor bed. It's difficult to say for sure what that is, and interpreting it can be a bit of an issue, but there are several steps put in place to try and address this. So things like acoustic coupling gel can have been sort of demonstrated to decrease that limitation. There's a good correlation between intraoperative ultrasound and post-operative MRI. I'm going to move on a little bit there in the interest of time. And then some of the advances in ultrasound imaging. So a lot of what I've shown is two-dimensional ultrasound, and I've done that because that's what I use routinely. And I think if you become comfortable enough with that, 2D ultrasound is incredibly useful. But particularly the group in Norway have published extensively and really pioneered this concept of 3D ultrasound, where the ultrasound imaging is integrated into your navigation and MRI scan. And during the resection, you can update these continuously. And they've demonstrated now, and there are several publications showing that this 3D ultrasound is incredibly useful in making the user interface more friendly, but also defining the borders of the tumors a lot better. Contrast enhanced ultrasound. This is an incredibly promising area of ultrasound imaging. And we're very privileged to have Francesco Prada chairing this session. He's an absolute authority on this. And he makes the point that you wouldn't really use just an MRI scan without some sort of contrast enhancement to better delineate the MRI scan. So to that same effect, contrast enhancement in ultrasound significantly enhances the quality of imaging. The limitation, though, is that it's not widely available. The contrast medium is quite expensive, and I'll leave that to Francesco to add some comments at the end. Strain measurement basically exploits the elastic properties of biologic tissue. So there are various algorithms. The acquisition is motionless, so it's quite easy to acquire the image, but it may be difficult to process them and actually interpret them. But it certainly is a promising tool, if not, mostly in a sort of research capacity before it reaches some sort of mainstream usability. Elastography requires a sweeping motion over the area of the image of acquisition, and this induced change separates the tissue measuring response. So then you should, in theory, be able to separate tumor from normal brain, and there are several publications on that. I have, for the interest of time, not included the high-intensity focused ultrasound, but again, so Francesco as well has quite a bit of experience in that field, and if it's something people want to talk about, we could include that in the discussion. So I'd just like to end then with this quote from Lennox Triates. Jay Forbes did the preface, and he said that it will ever come into general practice, I'm extremely doubtful, because its beneficial application requires much time and gives a good bit of trouble to the patient and the practitioner. And if we use this in the context of learning a new tool, new for neurosurgeons, I mean, ultrasound has been around for a long time. There is a steep learning curve, but I think it will make its way indelibly into our intraoperative practice. By the way, Forbes was talking about the stethoscope here, and we know how widely that was used eventually. So to summarize, then, ultrasound is safe, it's cost-effective, portable, non-invasive, diverse applications ranging from diagnostic to therapeutic and modulation. It's incredible potential both diagnostically and therapeutically, certainly worth making the effort to integrate into our routine practice. And with that, I'd like to thank you. So there are several workshops we run, or at least involved in teaching people how to use the ultrasound, both intraoperatively and to diagnose raised ICP. Thank you very much.
Thank you, Llewellyn, for this very nice and exhaustive presentation about the use of intraoperative ultrasound. I think you clearly showed how this is actually a tool that can help us throughout our surgeries. It's a tool that for sure is cheap, it's fast, it is real time, and it's really versatile, as you showed throughout your presentation, with application in spinal surgery, Chiari malformation, pediatrics, and brain tumor surgery. I think that in general, intraoperative ultrasound is underused in neurosurgery, and there are probably some misconceptions. The first one is that people say that it's not reproducible, it's operator dependent, but I think surgery itself is operator dependent. So as you pointed out at the end of your presentation, training, as for any other surgical application, is mandatory. Also, I think that, as you pointed out as well, apart from the training, the equipment is pivotal. Too often we use low-end machines, which provides a poor image quality. So I noticed that in your, and this is a question for you, I noticed in one of your slides you have a high-end machine, which means a machine with different probes, with different arrays, which provides a very good image quality and also allows to perform different modalities. How does this changes your understanding of the imaging, intraoperative imaging that you get, and how does this integrate in your workflow?
Thanks, Francesco. I know this is something you have a lot of interest in as well, and that's an important question. So a lot of times, people would ask, can I go down to the emergency unit and get the ultrasound machine that they use, or the machine that the anesthetist uses? The truth is, any ultrasound machine that you can get your hands on that has a decent quality probe would be a good place to start learning to use the machine. So like you pointed out, I mean, we're fortunate enough to have a very high-end ultrasound machine. That's because of the effort and intensity we put into, and we use it quite extensively. I don't think you need that intense or expensive a machine. I think the probe, if you can get a reasonable probe and get your protocol and the way you use it refined, I think you'll start to benefit from these sort of various applications. So you don't really need, you know, a very high-end machine is my opinion. I mean, I'm interested to hear what others think as
well. Thank you. So there is a question from one of the attendees, and they're asking what size and type of probe you use for during intraoperative tumor visualization.
You are muted, Professor. Can you unmute?
Sorry about that. Yeah. So we use a curved array probe. It's a small footprint probe. So it allows the benefit is that haven't really for a long time now had to increase the size of the craniotomy. This is for cranial work. It's an 8 megahertz probe with a small footprint. For the spinal work, we use this hockey stick probe that Philips make. It's a very small footprint probe. It's, if I'm not mistaken, I think it's an 18 megahertz probe. The reason we use that is because of the size of the probe. The other probe's too big. So really, you've got to tailor it to this to where you're operating, either spine or craniovertebral junction, or you know, a supratentorial.
Thank you. Go ahead, please.
Please.
I just wanted to add another comment to this discussion. So with Professor Padayachi, we've been running in the last 3 years many courses in person and webinars, and we found really a growing interest towards the use of intraoperative ultrasound. And Llewellyn mentioned that there are some advanced so-called modalities. We have to realize that these advanced modalities are well established in other organs. They are used routinely by radiologists. I'm talking about contrast and the use of contrast agents, which are a daily tool for preoperative imaging, like in CT or MR. So I don't see why we shouldn't use this during our surgery. So we are probably, as neurosurgeons, we are 20 years behind what is currently done in the general radiology realm. And this is because the brain and the nervous system has not been studied in a diagnostic setting because of the presence of the vertebrae and the skull. So the radiologists as well are not acquainted with this organ, but we have to understand that every time that we perform a laminotomy or we perform a craniotomy, we open a window to the brain and to the central, so to the nervous system, and this should be exploited in full to understand the pathophysiological mechanism of the system, because the ultrasound now it's multi-parametric. We have really more than BMO, than the Doppler. We have contrast. We can understand the tissue mechanics, tissue properties, perfusion of tissues. So apart from the image guidance, all this data, which can be collected and quantified now, should be collected, and they can help us understand pathologies, and they are also able to provide data to for therapeutic purposes as well, for the use of ultrasound as therapeutic tool and other therapeutic modalities. So I think really we should join forces and start collecting data in a homogeneous manner, and use the intraoperative ultrasound not only for the purpose of that moment, but also for a bigger, to understand a bigger picture.
Thank you very much. May I kindly inquire with Professor Padayachi that when he came to Mumbai before 2 years for the first international IOUS course, there was a software which everyone had to download, and we had to register, and we could train, had a training session with the phones. can you please give an update about this?
Yeah, so the update I'll give is a handover to Professor Prada because he's very involved with the Italian group. It's Professor Nico and Alessandro Perrin, and Francesca, I think you were involved in that as well. So I think you have a bit more. I will, yeah.
Please, Professor.
Yeah. Actually, it's a simulation tool. There is a library of cases, and you can log into a portal, and then you can use the oscilloscope and use your phone as a probe and see and rehearse cases, looking at them on the screen. So this can be an option, because for other organs, you can just take out the probe and stick it on the thyroid and look at it. But for the brain, this is shielded. One way to overcome this issue, and that we're studying and we are developing, is to replace the skull at the craniotomy window with cranioplasty that is compatible with ultrasound. So it has a very low attenuation. It doesn't deform the ultrasound beam. So the idea in the future is to perform follow-up with bedside ultrasound, and also in the future develop ultrasound guided instead of MR guided ultrasound mediated therapies such as blood-brain barrier opening or sonodynamic therapy or tissue ablation or neuromodulation with ultrasound.
Francesco, their website is Neurostim. Hey, what's it?
The website for the simulation is it's called Neurostream.
Neurostream. Okay.
Neurostream. That would be interesting.
Yes, sir.
So I suggest all our young neurosurgeons to go to that website. It is a very interesting website, and we had a great time rehearsing it in the first ultrasound course, which was held in Mumbai. I would like to open the floor for discussion. Yes, my co-host, Dr. Binoy and Dr. Liu would ask something.
Yeah, Professor, it was a very informative lecture. We have learned many important points from you. I wanted to know what is the role of ultrasound in skull-based lesions and the cerebellopontine angle lesions, and also for the transsphenoidal surgeries. What is the role of ultrasound in your experience?
So in those particular cases, the skull-based transphenoidal CP angle, it's difficult because the corridors are often very small. From memory, there are two papers published, both by the Trondheim group, with a specific probe that they used to help you, with a 360-degree view transphenoidally. So I use the ultrasound because of the particular probe I have for CP angled tumors. But the indications in that particular group are probably less than the run-of-the-mill hemispherical tumors or the intra-fourth ventricular tumors, where the corridor and exposure is a bit bigger. So for skull-based tumors, I think it's still quite limited in my experience anyway.
My co-host, Dr. Liu Bunse.
Thanks, Raja. Thanks, Professor, for a nice presentation. In my setting, we use quite a lot of ultrasound, especially for glioma surgery. May I ask, Professor, because now from the classical position, now we have moved towards a non-retractor contralateral approach. That is very against the use of ultrasound, mainly because of the water or saline that used as a medium. And you did mention about gel. Do you practice that, especially for intra-axial lesion where you use contralateral position? You cannot really actually use the ultrasound so much, that the difficulty I face. Secondly, I want to find out, you did mention about SINE MRI to look at the CSF flow. Do you think that in the near future, the ultrasound will be able to guide us the site of obstruction, especially in pediatric hydrocephalus? My last question, Professor, in terms of the position of the probe towards and with the so-called catheter that we're going to insert, which position you think is the best in terms of accuracy? Whether you should put it perpendicular or put side by side, one end to, or can you tell us what is the best position in between the probe and also the ultrasound probe and the catheter to give us the best accuracy in terms of insertion? Thank you, Professor.
Okay, thanks so much for those three questions. I'm going to start from the last one and work my way back. So there are two commercially available, I suppose, or two techniques based on what's commercially available. So the burr hole probe, a lot of people who use it swear by it. And I suppose it's one of those things where, you know, the more you use something, the more comfortable you become with it. I found the visualization with that burr hole probe not to be as great. So I prefer applying the ultrasound probe perpendicularly. And again, I need to acknowledge my bias here. Almost all the cases I've done were in neonates with an open fontanelle. So I had the advantage of kind of transfontanelle imaging and placement of the probe. The quality of the imaging I find is a lot better. But I think in adults, and there are new probes now that you can use, you know, transtemporally as well, which give pretty good imaging of the ventricle. So that's an option as well. So I've preferred that, and that's just by, you know, experience, or at least my experience of doing it. I suppose if you speak to somebody who uses the burr hole probe more, they would tell you, you know, it's pretty good. That hasn't been my experience. And then coming back to your second point, you know, I have not for a long time now had to adjust my craniotomy because of the ultrasound probe. And I don't think that would justify the use of it. I think if you're having to change your approach or your craniotomy or positioning just for the probe, I don't think it justifies the use. I think you need to integrate it into your normal workflow. And the modern probes tend to allow one to do that. So Gammon Ongskard has this beautiful slide where he shows if you position the head properly, so perpendicular, which is how you would do it anyway. When you fill the cavity up with saline, you know, you get the best quality imaging. You know, again, reinforcing the point that it shouldn't impose on your normal surgical workflow. It should rather enhance that. I hope that answers your question, Dr. Liu, or questions.
But the Siny MRI, Professor, would
yes.
ultrasound take over that function?
Yeah, no, you know, in time, maybe. I think there have been huge advances made, like Francesco's pointed out, and some of them we've kind of used in terms of blood flow and picking up those sorts of things. Cine flow with an ultrasound is difficult, because the reason I use cine flow is because, you know, with the bone intact, it's very difficult to get a reasonable ultrasound image. So the only imaging I get is post-bony removal. So to answer your question, at the moment, no. In the future, you know, potentially, but I'm not aware of anything that advanced yet.
Thank you, Professor.
Thank you very much. I can take one or two quick comments from Professor Atul Goel.
Yeah, that was a wonderful, very enthusiastic and very positive presentation from you, and I'm very happy to hear. I just wanted to ask you one question about low-grade gliomas, where I actually use ultrasound. I don't use ultrasound in any other situation but low-grade gliomas while during surgery. So what is your experience, and whether you can really define low-grade glioma from normal brain, and whether you have a reliable kind of description, whether you use it continuously during operation, and how much you use during surgery in low-grade gliomas? Can you just give me some few points on that?
Yeah. Thanks, Professor Gould. Thanks so much for that point. I mean, that's really the meat of this, you know. In low-grade gliomas, I think it's user-dependent. Always defining that interface between tumor and brain is very difficult to do. So the finer tools like the contrast-enhanced ultrasound are supposed to help with that, and the strain measurement, where you can pick up tissue densities, should help. But just a normal 2D ultrasound, it's incredibly difficult to do that. You know, I've used it because it's become very much part of my workflow, and when I'm not sure, I think, you know, it does often help, not always, but often. But in that context of low-grade gliomas, with difficulty would be my answer.
Okay,
and
thank you.
if I can add a comment, I totally agree with Llewellyn that elastography is very helpful in highlighting the tumoral tissue, because the architecture of the tumor is totally different and the mechanical properties are different. We also have to keep in mind that mostly for low-grade glioma, the boundaries, so the limits are functional. And again, the ultrasound is, there are functional ultrasound under development that can be used as a sort of bold MR, but they work with the same mechanism. And there is one paper published, and maybe in the future they can be used on a larger scale.
Right. Thank you very much. In that case, I think we can go back to our chair, Professor Prada, to say his concluding remarks. Please,
Yeah,
Professor.
there are no questions from the audience as well. Well, I think Llewellyn provided us with a huge overview of how intraoperative ultrasound can help us in our practice. And I think Professor Goel agrees that at least in early career, it would have been very helpful to have an ultrasound scanner in the OR. This is, I mean, I'm sort of mid-career. I found it very useful when I started, and when I started, the neuronavigation was the gold standard. But now, during surgery, not at the beginning, we rely fully on the ultrasound. I think also the ultrasound holds a tremendous potential for therapy, and maybe in the next meeting we can talk about this. And I think we're good for today. Thank you very much,
Thank you
everybody.
so much. It was a great presentation, and really we learned a lot from both the lectures. I would like to wind this up officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaita, I would like to sincerely thank both the speakers, Professor Andrew Kai and Professor Llewellyn Padiachi, and the chairs, Professor Dio Pujari and Professor Francisco Prada, for their time and support for the ACNS webinars. A special thanks to Professor Shubin from China, who is a mentor for us and has arranged a WeChat broadcast of this webinar in his country as well. The total number of live people who are watching us currently is 762 in various parts of the globe on various other streaming platforms. I would like to thank our co-host for today, Dr. Lyubun Singh and Dr. Binoti Damodar, for joining me, and also to all the distinguished faculties who have joined us, notably Professor Atul Goel, Professor Ibrahim Sebe, Professor Abhidas Shah, and many others from the different parts of the world. So until we all meet on the 26th of June, it is bye-bye from all of us. Thank you very much for joining.